Advances in the treatment of psychiatric disorders. This virtual Grand Round series examines research and advances across psychiatric conditions. It addresses many clinical challenges and barriers to treatment. These 20 sessions are ideal education for professionals in primary care, nursing, psychology, and family practice. You can use this free series to educate your entire staff in a community hospital practice of any size, or a practice of any size, and simply stay up to date as an individual clinician. The series provides CME credits for physicians, psychologists, and nurses. Each session includes live Q&A with faculty and is also available on demand. You can view the entire series or a single session at any time during the year. Slide. Next slide. These sessions provide consistent, high-quality, one-hour educational series that takes place every Wednesday at 11 a.m. beginning September 11, 2019 through July 10, 2020. Each 45-minute presentation is followed by 15 minutes of interactive Q&A. CME credit is provided by McLean Hospital, and we offer a special thanks to Alchemies and Takeda for their support of this educational activity. Next slide. I'm John Matthews, and I will be your moderator throughout the series. Next slide. The title of our presentation today is Implications of Psychiatric Genetics for Psychopharmacology. It is our pleasure to welcome Dr. Stephen Faraone from the Departments of Psychiatry and of Neuroscience and Physiology at SUNY Upstate Medical University. Next slide. To ask questions, you can type in your questions into the Q&A text box. You may submit questions at any time during the presentation. Questions will be answered at the end of the presentation. Questions will be answered in the order in which they have been received. Please be sure to make your questions concise as to allow other participants a chance to have their questions answered. Next slide. So at the end of the presentation, participants will be able to identify the implications of genomic studies for assessing the validity of subthreshold psychiatric diagnoses. They will also be able to describe molecular genetic studies that have attempted to predict drug response from DNA variants. And finally, analyze the rigor of different designs for assessing the efficacy of pharmacogenetically guided therapy. Next slide. And so it's my pleasure to turn the time over to Dr. Faraone. So welcome again.
Thank you, Dr. Matthews. These are my financial disclosures over the past 2 years. I do consult with one company that produces a pharmacogenetics kit for psychiatric disorders. I'll highlight that, the Genomic company, third from the bottom. And otherwise, the other companies are mostly for consulting about drug development in ADHD. We're first going to talk about how I think genomic discoveries may help us rethink diagnostic practices and how we make diagnoses. And then we'll move into pharmacogenetics, which for most of the lecture. You hopefully have all heard by now the concept of a polygenic risk score. I give the example of ADHD, which is my specialty, but it applies for basically all disorders in psychiatry, where we've discovered that there is a very strong polygenic background of risk that causes disorders. It may mean thousands of genes, tens of thousands of genes. We're still not sure about that. But here's an example of the distribution of ADHD's polygenic risk in 7,000 adolescents in the population. As you can see, it's a normal distribution. So from a genetic point of view, ADHD is not an either-or trait, it's a normally distributed trait in the population. But that's also consistent with the distribution of symptoms in the population. This is a study out of the Netherlands that looked at a population sample. And as you can see, just like the distribution of genetic polymorphisms, the distribution of symptoms in the population is also normally distributed and a continuum. ADHD is a dimension, not a category. The same would be true if we look at depressive symptoms in the population. It's a near normal distribution in this one study. Other studies have produced similar findings. And if you look at the genomics of depression, we also see that depression is a polygenic disorder with a normally distributed polygenic risk in the population. In addition to that, this is really, really interesting that the polygenic risk for psychiatric disorders tend to be correlated with one another. This is a study by the PGC, actually headed by Jordan Smolla from the Mass General Hospital. And this cartoon graph gives you the genetic correlations among different psychiatric disorders. The asterisks tell you which ones are significant, and the color, the darkness of the color tells you how large. If it's blue, it's positive. It's orange, it's negative. The important point here is that almost all of these disorders are correlated with one another in terms of their polygenic risk. And in cases where their correlations are non-significant, those tend to be for disorders that have smaller sample sizes, and those correlations might become significant in the future. And I highlight here in the boxes examples from the ADHD world where we see significant genetic correlations with schizophrenia, depression, bipolar disorder, autism spectrum disorder, Tourette syndrome, and a negative correlation with anorexia nervosa. All of the other correlations are positive. And these correlations really fit very nicely in what we've seen in genetic epidemiology of ADHD for the past 2 or 3 decades, including studies that I did 20 years ago with Joe Biederman when I was at the Mass General Hospital. So very important that psychiatric disorders normally distributed in the population genetically correlated with one another. So given this information, can we use DNA to make psychiatric diagnoses? Well, absolutely not. We're not at that stage yet. Many of us hope that we can, but these scores are not sufficiently accurate to make diagnoses. I do hope that as samples get larger and as our algorithms get better, we may be able to make such predictions, but that I think is still in the distant future. I do think that these genetic studies tell us a good deal about how we think about psychiatric comorbidity. Some of the younger folks might not know this, but say 20, 25 years ago, there were huge debates about the validity of psychiatric comorbidity. There was a time when you couldn't diagnose depression and panic disorders together. There was a time when literally Joe Biederman was ridiculed for saying that ADHD could co-occur with depression. It was back in the 1990s. And now we know that there's pervasive comorbidity in the clinic and in population samples from epidemiology. And now the genetic studies tell us that there's a biological basis, at least in part, for this comorbidity. And so the bottom line for diagnosticians is that we should expect that comorbidity is the rule, not the exception. And really, one should expect pervasive comorbidity, that somebody with one disorder has a high likelihood of having another disorder. We also know that we need to think about disorders as dimensions. And that's a bit of a conundrum because as a diagnostician, you have to say either or. The person has a diagnosis and is treated or doesn't have a diagnosis, and you don't treat them for the disorder. And yet, I do think it helps to think about diagnoses as dimensions. For example, it changes the way we think about subtypes. We used to always think there were subtypes of schizophrenia, subtypes of ADHD, subtypes of depression. There's a huge, huge literature on each of these. And yet, it seems that each of these subtypes is simply a different expression of the underlying quantitative dimensional risk of these disorders. Some people talk about early versus late onset subtypes. These may simply reflect severity on the continuum, more severe cases having an early onset. And perhaps most importantly, the dimensional view of disorders that we now derive from genetic studies suggests that subthreshold disorders make sense not only genetically, but perhaps also diagnostically. Now, here's some examples from the clinical literature of why subthreshold diagnoses might make sense. This is a paper I published with Joe Biederman's group just last year. Now, you can't read these graphs, but the point is to show you that there's lots of data, not to understand each individual data point. We did this meta-analysis, and what we showed in the meta-analysis was that subthreshold cases of ADHD, these were children referred to the MGH Pediatric Psychopharmacology Clinic, children that were subthreshold, they certainly were milder than full cases of ADHD, cases that had full diagnostic criteria. And yet, compared to controls, these subthreshold cases showed more psychopathology, more school failure, more neuropsychological impairment, more substance abuse, more psychosocial impairment. They showed a pattern of impairment and disabilities that was very consistent with an ADHD diagnosis. making one think that these people fall just below the threshold, perhaps, of having ADHD, but they shouldn't be ruled out as having a clinically important degree of ADHD just because they don't meet the DSM criteria. We also published a meta-analysis of pediatric bipolar disorder looking at subthreshold cases, and we had a similar conclusion that subthreshold pediatric mania was associated with a greater functional impairment, greater severity of manic and depressive mood symptoms, higher rates of disruptive behavior and substance use disorders, and higher rates of suicidal ideation and suicidal attempts compared to typically developing controls. Again, subthreshold conditions seem to have clinical import. And finally, this is some data from a study of adults with depression, which showed that in a meta-analysis, there was no difference in mortality between people who had full threshold depression and subthreshold depression. People with major depression had a somewhat increased risk of premature death, but it was not statistically significant. So the bottom line is that we need to take a dimensional view to disorders, and instead of thinking about people as having a disorder or not, thinking about to what degree do they have a disorder, and not to penalize people because they just fall below the diagnostic threshold. Okay, let's move on to pharmacogenetics, the genome and drug response. Are we ready for personalized medicine? Certainly it's kind of a holy grail in genetics if we can personalize the medical treatment for individual patients as opposed to a one-size-fits-all type of treatment. The theory is very sensible. We start on the A side of the graph. The current approach is you have a syndrome that consists of different types, different groups of people. We call them green, red, and blue here, but they all get one treatment. But ideally, with pharmacogenetics, you can define different syndromes, and those would have different genetic variants, and those would get different, more precise treatments. Is that possible? Well, first, let's ask why should we be interested in pharmacogenetics? Of course, the main reason is that the one-size pharmacotherapy doesn't really work. And you all know that from clinical practice. You have to find the right medication for the right patient. The drug you try first doesn't always work. If we could replace a trial and error treatment with a targeted treatment, wouldn't that be wonderful? And it would. And there's also the ability, perhaps, to use genomics to predict adverse events. If you could predict adverse events, it would help drug development because some drugs that couldn't get to market because of adverse events could come to market. And if you could predict as a clinician adverse events, it would help you choose which medication is the best medication. So we think of pharmacogenetics in two levels, pharmacokinetics and pharmacodynamics. As you all know, drugs administered, it has to develop a concentration in the circulation that's affected by the distribution to tissues, elimination, metabolism, excretion. These are all controlled by pharmacokinetic features, which are controlled by genes to some extent that control pharmacokinetics. And then there's a pharmacodynamic side, is the action of the drug at the receptor in the brain where it works and gives a pharmacological effect that leads to efficacy and/or toxicity. Goal of pharmacogenetics is to try to predict both of these, pharmacokinetics and pharmacodynamics. I'll take each of these in turn with some examples of what we found, and other people have found, not just me, in the literature. Antidepressants have been studied to death in the pharmacogenetics literature, particularly in the CYP2D6 system, which has a lot of variants that control the pharmacokinetics of antidepressants. What you see here on the horizontal axis is a list of antidepressants, and they're organized from left to right, the degree to which they're impacted by pharmacokinetic genes. On the right-hand axis, you see PM means pervasive metabolizer. We have intermediate metabolizer, extensive metabolizer, and ultra-rapid metabolizer. So pervasive people, the P is poor, poor metabolizers metabolize poorly, and so they have high levels of drug in their circulation. The ultra-rapid metabolizers metabolize very quickly, and so for the same dose, they don't get as much drug into the system. So you can see on the far left with the imipramine, we're looking at what is the dose adjustment one would need to get the same effect for the average person. Well, for imipramine, you can see dramatic differences between poor metabolizers who only need 28% of the dose versus, say, ultra-rapid at the top here, who need almost 200% of the dose of a typical patient. And as you can see, if you go all the way to the right, to sertraline, sertraline not at all affected by these particular genes. and therefore dose adjustments aren't needed. So these data are very strong, very real, very statistically significant. Moving on to, and I just showed you for depression. This is for ADHD, just some examples. There are CES1 variants that predict the poor metabolizers of methylphenidate. We know that 20% of Caucasians are poor metabolizers to amphetamine due to CYP2D6. And we have other similar types of phenomena with amphetamine and with atomoxetine, where the CYP variants control metabolism and lead to different rates of metabolism that potentially could be useful in clinical practice. Moving on to the efficacy response. This is one example from the ADHD world. It's a meta-analysis I did 2 years ago. And here you see we got 6 genes that were looked at enough to have enough studies to look at the pharmacogenetics of methylphenidate. And 5 of these 6 show statistically significant statistically significant effects. And of those 5, four of them showed no publication bias. So those are pretty solid findings that these polymorphisms control to some extent the efficacy response to methylphenidate. And as you might imagine, because people that study pharmacogenetics tend to pick genes that are relevant to the disorder, these are all genes that work in the dopamine system or the norepinephrine system. Just one other example, meta-analysis of antipsychotic drug-related weight gain. A lot of studies, 72 articles, total an N of 6,700 across all those studies. So there's a lot of information. Looking at 38 SNPs, those are genetic variants from 20 genes. They found 16 statistically significant associations. You can see the Hedges G is the standardized mean difference effect size of 0.3 to 0.8. The odds ratios range from 1.5 to 1.9. And like the ADHD odds ratios, not huge, but they were statistically significant. These authors concluded that antipsychotic weight gain is polygenic and associated with various specific genetic variants, but did not conclude that it was ready for prime time in terms of using it in the clinic. If we look at this, take another review article that came out recently. This article, again, comes up to the same conclusion. It reviews the literature. Yes, there are significant correlations, significant pharmacogenetic findings, both in pharmacokinetics and pharmacodynamics, but their conclusion was we weren't close enough for schizophrenia and bipolar disorder to bring those tests into the clinic. Well, how do we decide whether these tests are clinically useful or not? The actual data that I've shown you, and much more data that's out there in the world in terms of looking at specific genes, is fairly strong in the sense of statistically significant. The problem is that many of the effects that occur, for example, the fact that certain polymorphisms control the metabolism of tamoxifen, for example, or antidepressants, for example, those types of issues can be resolved by the clinician by using slow titration in clinical practice. And that's why pharmacogenetics hasn't really been used for the past few decades, even though we've known for at least 2 decades about the pharmacokinetic genes. The effect of the DNA variants on the pharmacodynamic response is much weaker, and there the predictive value is very low and questionably useful in the clinic. But importantly, for the way you think about pharmacogenetics, when you read the literature and you talk to people who are trying to sell you pharmacogenetic kits, is that the genetic association studies are not sufficient for saying, is a pharmacogenetic finding clinically useful? We need something else. Well, what is that? What kind of data do we need to show that pharmacogenetics is useful, or to show that pharmacogenetically guided treatment, sometimes I'll call that PGT, how do we know that that's useful? Well, the first tier is the best type of trial, and that's a randomized controlled trial that compares a protocolized treatment as usual, tau, with the pharmacogenetically guided treatment. Protocolized treatment is what it sounds like. It means that it's treatment, but it's well defined to the clinician how they should proceed in terms of first line, second line, third line, et cetera, under what conditions for what type of patient. Without pharmacogenetic information, the pharmacogenetic treatment is a protocol, but it also includes the pharmacogenetic data. Then there are studies that use randomized controlled trials that just compare tau with PGT. And then there are some electronic medical record studies or health insurance type company studies that look at tau, compare tau with PGT, and look at cost. So let's start with those studies. They're not the best studies, but they're still quite interesting. Here's a study that was produced by some of your colleagues at the Mass General, Roy Perlis, among them Richard Fafa. And they looked at the costs of pharmacogenetic treatment. And what they found was that, and they also looked at adherence. So they found that what we call assay-guided treatment, but it's pharmacogenetically guided treatment, was the individuals that were given the assay-guided treatment were significantly more medication adherent. Extremely important. We know that adherence is very difficult for psychiatric conditions. They were significantly more adherent, and they showed a relative cost savings of about 10% in their outpatient costs. And over a 4-month period, that totaled an average of about $500 in cost savings. So there is some evidence that the pharmacogenetic treatment is good from the point of view of costs. Another study from, in part by the MGH group, also looked at electronic data, comparing health claims data from a US insurer, comparing PGT with tau. I'll show you here a graph from their paper, which you can see here in green is the cost for the controls. These were matched by demographic and other variables to the cases receiving pharmacogenetic therapy. So the controls are people with depression not getting pharmacogenetic care, just getting treatment as usual. The blue are people getting PGT, pharmacogenetically guided treatment. And as you can see from the slide, in each of these categories, with some variability, there's greater costs in the treatment as usual compared to the PGT. And when you look over the 6-month period, there's about a $2,000 savings in the PGT group compared to the matched controls. Well, let's move on then to the question of, does pharmacogenetic treatment actually improve outcomes? This is a small meta-analysis of only 5 studies looking at randomized controlled trials of PGT versus tau. And what you can see here on the horizontal axis is your odds ratio for the risk ratio, I'm sorry, for improvement. And as you can see, 3 of the studies here, because the square basically, the dot inside the square is the odds ratio, the horizontal line is the confidence interval. So when the confidence interval doesn't cross the vertical line, it's significant. So 1, 2, 3 studies were statistically significant, 2 weren't, but as a whole, this diamond at the bottom tells us when you combine them together, we find significant evidence that there's more symptom remission with pharmacogenetic treatment. However, of concern is that this heterogeneity statistic is very high, 71%, which makes us think that we have to be careful about putting too much weight, too much belief into these results, because the results differ so much among studies, it's hard to draw from conclusion. As an example of the problems we face with the pharmacogenetics literature, this is a study which was in that, here it was in this meta-analysis. And in the meta-analysis, they used the symptom remission outcome in the so-called guided trial. This study caused a big deal of controversy. It was an APA meeting about maybe 2, 3 years ago. Literally, it was big debates, people using loud language to talk to each other about the quality of the study. And then one big complaint was that the pharmacogenetic testing did not improve mean symptoms, which was the study's primary outcome. Although it did improve response and remission, which we saw in the meta-analysis, but that was a secondary outcome. So some people said, well, if you didn't hit on your primary outcome, you really shouldn't be claiming that it works. And there's a lot to be said for that. For example, the FDA only accepts primary outcomes as proof that a drug works, and therefore one would expect that we would want a pharmacogenetics approach to hit on its primary outcome. Although that said, the fact that it did hit on its secondary outcome is, of course, interesting and should not be dismissed out of hand. If there's anything you'd like to read about pharmacogenetics, I would look at this really at op-ed viewpoint piece in JAMA Psychiatry by George Zabenko and others, including Bruce Cohen at Harvard, which is essentially a critique of the pharmacogenetically guided treatment study literature. They say a few things, but I'll highlight one important point in the table. You can see here a little bit bigger. And what they point out, if you go from top to bottom, you go from, studies that aren't very good in terms of their study design to studies that are very good. So you can see there's not very many studies, but at the very bottom, there are no studies that are the ideal study They're blinded and have a protocol-based comparison. These other studies suffer from being either partially blinded or not blinded, and none of them use protocol comparisons, which Zubenko et al. Insists is necessary to conclude the efficacy of pharmacogenetics. And I have to say there's some debate there as to whether it's necessary or not. So let's talk a little bit about what that means, because it is important when you read pharmacogenetics literature, and you will be reading more of that as time goes on. Zubenko et al. Argue that in many settings, treatment as usual is actually below the standard of care. So you have physicians, nurse practitioners, others not prescribing outside of treatment guidelines. Typically in the pharmacogenetics kits, in addition to getting the pharmacogenetic information, there's some information there about treatment guidelines. And the pharmacogenetic guidance does try to keep people within guidelines as well as improving upon guidelines with the pharmacogenetics treatment. And because of that, Zubenko and colleagues argue that when PGT is better than tau, we don't know if it's due to the genetics or if it's due to the protocol. And so they prefer to see a difference between protocolized tau versus PGT. And as a researcher, I can see why that makes sense. It would tell you what works. It would tell you what the mechanism is that works. Now that said, if PGT just beats tau regardless of protocol, it does tell us the PGT is doing better. We just can't separate out the protocol side from the pharmacogenetic side. Well, let's look at what we know from other authorities that have looked at this. Well, the FDA came out with an interesting statement in 2018. I'm not going to read it to you. FDA is aware of genetic tests that claim results can be used by clinicians to identify which antidepressant medication would have increased effectiveness or side effects compared to other antidepressant medications. However, the relationship between DNA variations and the effectiveness of antidepressant medications has never been established. Wow, this is kind of in some ways, well, it's a very strong statement. It's very clear what they think, and you should know that. It's a little strange because the same pharmacogenetic testing kits they criticize have been cleared by the FDA. So why do we see this? We see FDA clearance for pharmacogenetic kits, and then we see the FDA saying, "Oh, hold it, be careful, don't make statements about the efficacy for depression." And the reason for that discrepancy is that FDA clearance is different than FDA approval. So we all know that FDA drugs are approved. That drugs are approved by the FDA, but that's a very high bar. To cross that hurdle, you have to prove to the FDA efficacy and safety with very, very rigorous experimental designs. The bar for FDA clearance is much lower. We're not going to get into the details there, but it's a lot lower, and therefore companies can get things cleared that aren't necessarily clinically useful. So you need to know that when you think about FDA clearance for pharmacogenetic kits and understand why it is the FDA has said this about depression. Moving on, the American Psychiatric Association had its own task force on gene testing for antidepressant efficacy. And I should say the focus has been on antidepressants because that's where there's been the biggest literature and the most interest in the clinical world, and also to some degree among patients and family support groups who have gotten a hold of this. The APA task force concluded that the data supporting pharmacogenetics was flawed because of, well, number one, as I've said, the significant association was typically weak. We could mitigate the effects of PK genes by titration. There was poor control of protocolized care in the clinical trials, failure of primary outcomes in some of the trials that had been published as being positive. And this is a concern that the APA raised, which is kind of interesting, that they're concerned there's really no transparency about the algorithms that companies are using to look at multiple genetic variations. And they think, and I agree, that the companies really should be open source about this. We really should know how they're making their decisions. Moving on to the American Academy of Child and Adolescent Psychiatry, they also had a pharmacogenetics testing task force. And their conclusions are here for you. They certainly don't see it as a first-line approach in terms of cost effectiveness. So they were not impressed with the cost effectiveness literature or with the efficacy literature. They thought that there were many genetic variants that were included in these panels that were essentially irrelevant to drug effectiveness given currently available data. And then But they did say that tests for drug metabolizing enzymes could have some utility for those patients that have unusual side effects profiles or are treatment resistant. And so that's a very important, I think, important take-home message, that where you have a patient that you have trouble finding something that works, you'd like to give them something that really should work, should be efficacious, but for some reason they're not responding. Here, knowing their pharmacokinetics could be useful, because then you might end up having to give them a much, much higher dose than you normally would. There's one potential concern about pharmacogenetically guided therapeutics that we really know very little about. So these are really more kind of thoughts I've had that are not, I wouldn't say totally innovative thoughts. I've been reading the pharmacogenetic literature, listening to people talk about it, and these three things come up a lot. One of them is that, you know, the time you spend reading and interpreting the pharmacogenetic test reports might be better spent doing something else. You know, people are very busy, so we really want to be sure that it's worthwhile spending time doing this. There is a financial cost typically to the patient, because insurance companies don't typically cover pharmacogenetic kits. And then there's the potential that following pharmacogenetic guidance might decrease adherence to very well validated evidence-based treatment guidelines. So for example, if somebody said, well, gee, I'm going to use a non-stimulant for ADHD because my patient is a funny metabolizer of stimulant medications, well, that really is not a good idea, because if you could solve the metabolism problem just by titration, your patient could have a more efficacious medicine as opposed to a less efficacious one. You could still prescribe within guidelines, in this case with ADHD, the stimulants being the first treatment of choice as far as most guidelines are concerned. And there even was one study that came out of Hartford. I don't think it's been published yet. I've only seen a presentation, which actually showed in a small study that clinicians using pharmacogenetically guided treatment were less likely to follow standardized evidence-based guidelines. We need to know more about that, because there's some disagreement whether that would happen or not. But whatever does happen, the people using PGT need to address treatment guidelines within the PGT approach. Okay, I'm getting close to the end of my talk. If you are interested in pharmacogenetics, this site has the most updated information about evidence-based pharmacogenetics. It's CPIC, Clinical Pharmacogenetics Implementation Consortium. CPIC is essentially a consortium of mostly academic researchers that curates studies and meta-analyses that have come out of literature, and then presents information and their views on the utility of those particular pharmacogenetic findings. Okay, let me summarize what we've said today. Number one, most psychiatric disorders are clearly polygenic and share genetic risk factors with other psychiatric disorders. I've ignored for now the fact that there are some very rare single gene variants of psychiatric conditions, but they are rare and therefore not as relevant to the big group of people that you treat every day. And also, we know very little about their treatments and anything specific to their treatments. The genomic and clinical data each support the validity of subthreshold psychiatric diagnosis. We know this from the polygenic background is normally distributed. The clinical data in terms of symptom counts is normally distributed in the population. We also know from some studies, for example, like in the ADHD studies, when we correlate the genetics of ADHD with the genetics of, we correlate the genetics of ADHD as defined as a disorder, and we correlate that with the molecular genetics of ADHD defined as just as symptoms in the population. We find that the genetic correlation between these disorders, and by that I mean the correlation between their DNA variants, is almost 1.0. It's almost perfect, which tells us that indeed that background, polygenic background, is the same in the population, supporting the idea that ADHD is a dimensional disorder. This idea is important to you all because all of a sudden subthreshold diagnoses, I think, become more important and more relevant, because these are not necessarily, as some people might say, diagnostic errors. These perhaps are simply people who are just below the threshold for diagnosis. I have shown you that DNA variants are associated with the pharmacokinetics and pharmacodynamics of drug response. Yet these effects are small, they're very real from a statistical significance point of view, but they tend to be small, especially the pharmacodynamic findings from a effect size point of view. There's medical record and health insurance data that suggests that PGT, pharmacogenetically guided treatment, may decrease costs. Important finding. But yet the actual outcome data is sketchy. We don't have any studies yet that use the best possible protocol. And the studies that use protocols that aren't as good are still questionable because there's a lot of heterogeneity among study disagreements, and studies that are somewhat positive have sometimes failed in their primary outcome, which makes them difficult to interpret. That said, thank you for listening. If you're interested in ADHD, come to the World Congress in ADHD, which we hope we'll be having in 2021 in Prague, in person, if not perhaps online. Thanks very much for listening, and I believe we still have time for questions.
Thank you so much, Dr. Faraone. And why don't we move on to some questions, okay? For our first question, why did the FDA express concerns about pharmacogenetic tests for depression, given that they had previously approved these tests?
Their concern arose because they were getting complaints from the field. And this is based on my discussions with people I know at the FDA and other conversations I've had. So take it with a grain of salt, it's all kind of hearsay. They were getting feedback from the field that pharmacogenetic kits were being marketed too aggressively. That's one reason. They, I'm sure, did their own internal evaluation of the quality of the evidence and came up with their own conclusion as well. And as I said before, even though they had cleared them, the bar for clearance is much lower than the bar for approval. And so they wanted to warn the community that just because these were cleared kits, they weren't necessarily efficacious. They shouldn't be taken on face value, that it was, in a sense, they were leaving up to the clinician to decide whether these are useful or not.
From my own personal experience, I have used the cytochrome P450 genotyping to help sometimes with some patients who were having either low efficacy or very sensitive side effects. I had one patient who, when I did the genotype, she was very sensitive to medication, multiple side effects on a variety of antidepressants. But I found out that she was a slow metabolizer across several of the CYP genotypes. Yeah. And that led me then to switch to an antidepressant that was primarily metabolized by the kidney. And she did very well. So I don't have a lot of examples of that, but that was one case where it did pay off. The other issue is trying to see if any insurance companies paid for the genotyping. Can you comment on that?
My understanding is that it's insurance coverage is limited. Last time I checked, I think nobody was insuring it. Possibly somebody is now, but it's insurance companies are limiting its use.
Yeah, and sometimes I guess I've had to write a letter, but that doesn't always work either.
Right, and you gave a very good example, and that's the case where I think there's little debate that pharmacogenetics can be useful. You've got a patient, difficult to figure out, treatment non-responsive, weird adverse effects. You'd like to keep them on a more effective drug, and you want to solve the problem. That's a good use of pharmacogenetics.
Yeah. Okay. Another question: is there any value to pharmacogenetically guided therapy as a suitable means to encourage protocolized treatments?
Well, that's a great question, and again, there's one which is debate. So you could argue, and I think this is reasonable, that if the pharmacogenetics companies, they're selling these kits, obviously they're out there, they're commercial, they want to make money, that's their goal. But if they're also providing a service by helping people with protocolized treatment, and this obviously, psychiatrists at Mass General don't need their help, but in the field, there are a lot of docs, nurse practitioners who haven't had a lot of training in evidence-based care for depression, ADHD, fill in the blank, and these protocolized pharmacogenetic treatments may actually be helping these people, which may explain why a study that what Perlis and others did about costs were showing improvements in costs, because in the real world, these are perhaps working better. And so I do think that Semenko et al., although they're correct in terms of what they were saying in terms of how the quality of the studies, I would not completely dismiss the PGT versus tau studies where the tau studies are not protocol.
Okay. Where do we draw the line when deciding someone with a subthreshold disorder should be treated? That's a biggie.
Yeah, it's a huge question. Well, I think I would say that we really draw the line at impairment. So clearly, you want if somebody has a few symptoms and they're not impaired by the symptoms, it's not clinically worrisome. If somebody there are people that have 3 symptoms of ADHD and are massively impaired by those symptoms. Those people deserve treatment. They're subthreshold. Clearly you want to do more investigation of those cases, be a little more careful. You may want to find out about their family history of ADHD. They want to find, especially if they're adults, you want to find out a little bit about how they functioned when they were children. But still, even many adults who are coming to the clinic for the first time won't recall because of recall problems, won't recall their history. So there's a lot of clinical judgment, but I would say impairment's the most important thing. You want to see not just that the person's impaired, but that the symptoms of the subthreshold condition cause impairment.
Yeah, I mean, I think I always look for the functionality. I don't adhere completely to DSM-3 checklist and so forth. I look also at are there symptoms impairing function in some important domains of their experience, and because I think you do have to pay attention to subthreshold conditions and not get too wedded too well. They have to meet the criteria before I treat. So,
yes.
Right. Okay. Well, Liz, I don't know if there are any other questions that came up.
I don't see that any other questions have been submitted at this time, so it looks like we are all set. Thank you so much, Dr. Faraone and Dr. Matthews.
Okay.
Thank you.